The patient will be presenting as a 70-year-old male with a 40-pound weight loss, lethargy, and decreased appetite. For the HPI and review systems, he was a 70-year-old male who presented with loss of appetite for 1.5 weeks and weight loss. Per the Sun, the patient had lost 40 pounds over the past 2 to 3 months. The patient admitted to an increase in lethargy, weakness, feeling depressed, a decreased appetite, feelings of sadness, and loss of interest in activities since his wife died 2 years ago. He denied any suicidal or homicidal ideations, had a big family, and wanted to live for them. He stated that last oral intake was 1 week ago and last bowel movement was 1 week ago as well. He denied any pain with bowel movements or urination, but endorsed increased frequency of urination. His last colonoscopy was 20 years ago and it was normal. The patient is able to walk and perform ADLs independently. However, he felt more weak the past week and has needed to use his cane. He admits to dry mouth and dry lips. He denied any chest pain, palpitations, abdominal pain, nausea, vomiting, dysuria, hematuria, or any problems with urinary flow. The patient had no pertinent past medical history but had not seen a physician in over 20 years. He had a back surgery 50 years ago, and he did use tobacco, alcohol, and marijuana regularly. Of note, in the patient's lab values, there was a white blood cell count of 34.2, a hemoglobin of 6.7, and a lactic acid of 1.1. Those were the most important in this case because we were worried about sepsis with the white blood cell count of 34.2, and then we also knew that we could potentially transfuse this patient because he had a hemoglobin under 7. On exam, the most prominent features were the fact that he appeared malnourished, he had prominent cheekbones and was very thin, he appeared dehydrated, and then on gastrointestinal exam, he had mild diffuse tenderness to palpation, especially in the left lower quadrant and right upper quadrant. He had a large, soft, round, mobile periumbilical mass, approximately 10 centimeters in greatest dimension, but was not painful to palpation and unable to be reduced. On genitourinary exam, he had a large scrotal mass, approximately 30 centimeters in greatest dimension. It was not tender to palpation and was unable to be reduced as well. There was also overlying eschar at the inferior pole of the mass with the largest, approximately 7 centimeters at greatest dimension. On the CT images, you can see the scrotal hernia with small bowel and bladder being displaced with inside, also a hydrocele. There's also a ventral hernia in the central abdomen and 2 abscesses in the left lower quadrant and right upper quadrant as well. For differential diagnoses, we had a wide range of reasons and causes potentially for these large hernias. First, we had malignancy, major depressive disorder, failure to thrive, alcohol use disorder, sepsis likely due to the peritoneal abscess, incarcerated or strangulated, periumbilical and inguinal hernia, a bowel obstruction from these hernias, a sigmoid volvulus also could be resulted of these hernias, diverticulosis or diverticulitis due to the patient's age and general population. For our patient, we had 3 final diagnoses. We had a giant inguinal scrotal hernia, septic abdominal abscesses, and a ventral hernia. A giant inguinal scrotal hernia is defined as an inguinal hernia that passes the midpoint of the inner thigh when standing, and this size is normally due to neglect or fear of the surgical procedure. And then just some facts, it normally occurs in rural populations, and the most common symptoms are urinary retention, difficulty voiding, and pressure sores along the medial aspect of the scrotum.
A hernia occurs when an organ or part of an organ protrudes to the body wall that normally encloses it. Groin hernias, which include inguinal and femoral hernias, result from a weakening or disruption of the fibromuscular tissues of the body wall, allowing abdominal contents to push through the defect. Risk factors include male sex, age, a family history of inguinal hernias in first-degree relatives, impaired collagen metabolism, and a history of open prostatectomies. Inguinal hernias can be classified as indirect or direct hernias. Complications include incarceration, which occurs when the hernia contents become trapped in the hernia sac, making it impossible to return them to the abdomen or pelvis. This can lead to reduced venous and lymphatic flow, swelling, and potentially compromised arterial flow, resulting in ischemia and necrosis of the hernia contents, which is known as strangulations. Symptoms and physical findings most commonly include heaviness or dull discomfort in the groin with a visible bulge. Moderate to severe pain is uncommon and may indicate incarceration or strangulation, which presents with symptoms of small bowel obstructions. Treatment can be watchful waiting for non-symptomatic hernias, but laparoscopic surgery is recommended for many hernias. Our patient did not want further surgical interventions on his hernias, so we treated him with IV antibiotics and multiple drain placements for his abdominal abscesses. He was sent home after clinical improvement. On outpatient follow-up, his drains were removed and his sites were healing well. A CT showed no new abscesses. He stated that he was doing well overall. He has a great appetite, normal bowel movements, and improved level of activity back to his baseline. He still continues to not want to pursue surgical intervention to repair his hernias. We chose this case for many reasons. One reason was mostly the sheer size of his hernia. The non-obstructive umbilical, inguinal, and scrotal hernia contained his colon, small and large bowel, and large portions of his urinary bladder. It was the largest we had seen. Another reason was because of how broad we were able to make the differential, because he came in with such non-specific complaints. We utilized a multidisciplinary approach to ensure that all his needs were met and that we weren't missing anything major like cancer while treating his abscesses and managing his hernias. And lastly, we chose this case to highlight the importance of patient autonomy and respecting the patient's wishes. He did not want surgical intervention, and as medical professionals, sometimes it may be hard to navigate the fine line between treating a patient but also respecting their wishes. That is the end of our presentation. Thank you so much for your time.